Hi, everybody, and welcome to this Aspen Ideas Festival conversation. I am Amna Nawaz. I'm the chief correspondent at the PBS NewsHour. I am honored to be moderating this conversation today, and we have some wonderful guests with us. First up is Dr. Lena Wen. She's an emergency physician, public health professor at George Washington University, and non-resident senior fellow at the Brookings Institution. She's also the former City of Baltimore Health Commissioner. Dr. Wen, good to see you. Thanks for being here.
Thank you very much. Great to join you.
Also with us is Congresswoman Lauren Underwood. She's a Democrat representing Illinois' 14th District. She serves on the House Committee on Veterans Affairs and the House Committee on Appropriations. She also co-founded and co-chairs the Black Maternal Health Caucus. She's also a member of the Future Forum, the Congressional Black Caucus, the LGBT Equality Caucus, and the Gun Violence Prevention Task Force. Congresswoman, good to see you.
Thank you for having me.
And also with us is Dr. Gary Butts. He's the Executive Vice President and Chief Diversity and Inclusion Officer at Mount Sinai Health System. He's also Dean for Diversity Programs, Policy, and Community Affairs for the ICANN School of Medicine at Mount Sinai. Dr. Butts, welcome to you.
Thank you for allowing me to participate with this esteemed panel.
Thanks to all of you for joining us as well. So I think we've talked a lot about this. I know I've certainly covered this a lot over the last year, but the COVID pandemic really laid bare the deep inequities in our healthcare system. We saw a disproportionately high number of cases, hospitalizations, and deaths among Black, Latinx, Asian, and Native Americans. And those outcomes, as we know, reflected long-standing underlying health and housing and environmental conditions for many, on top of unequal access to healthcare and gaps in insurance coverage. So we're going to focus on the big ideas that have come out of this last year to help close those gaps, the kinds of ideas that could change the way we think about and provide healthcare moving forward. So let's start with innovations. And Dr. Butts, I'm going to throw this to you first. I want to talk about what stands out to you as something new, something that came out of this, the tragedy of the last year that worked, that actually helped to improve healthcare and health equity. What stands out to you?
I can what stands out, two things. One is that as Spotlight became more visual and vivid on some of the clear disparities and the disproportionate burden for people of color in accessing care and the outcomes, so did the spotlight get shined on access to technology and all of what that could mean to either benefit our communities or widen the gap. And so telehealth, telemedicine, telehealth, and advancing that in ways that benefit us all, I think, has begun to happen. Clearly, there are lots of challenges that have gotten in the way, but we at least are positioned to understand them, to leverage this moment perhaps a little bit further, to close the gap with telehealth equity for communities of color, so that indeed we all benefit from the advances in innovation.
Dr. Wen, what about you? Is telehealth one of those that stands out to you as something we should have been doing a while ago?
Well, certainly, I have been a proponent and a practitioner of telehealth for years, and I think so often there has been this tendency to put barriers in place, as in people come up with all these reasons. And by the way, HIPAA is probably one of the most misused terms that is thrown up as a reason for why we can't do certain things. But actually, we saw that when the pandemic struck, that all these practitioners and patients started doing telemedicine, and I think have really benefited from it. And I hope that moving forward, we're not going to replace brick and mortar. There's definitely going to be a role for brick and mortar, but I think we should be considering healthcare in a more holistic way, thinking about the integration of care. For example, there is a role for home-based care. There is a role for telemedicine. There's even a role, when I was the health commissioner in Baltimore, we started telemedicine in our schools, because even though we often think about telemedicine for rural areas, there are a lot of urban areas that lack access to, for example, mental health specialists. Why should children also have to miss school to treat their asthma if that's something that could be very easily treated in their schools? And so I very much agree with what Dr. Butt said. I think that the promise of telemedicine is great, but one of my concerns is that unless we are specifically attentive to addressing disparities, these disparities are going to widen. And those who are very privileged will be able to access all these services versus those who are already left behind. We need to be sure that whatever innovations we have specifically address closing disparities and promoting equity.
Congresswoman Underwood, what about you? We've mentioned telehealth, but also, as Dr. Wen pointed out, there were gaps in accessing technology and being able to access healthcare in that way anyway. So do you consider that something as a big idea that was a solution, something we should be carrying forward?
Well, I do think that there is absolutely a role for telehealth expansions, and we know that this has been a very popular solution and innovation that's been helpful for certain populations. There are barriers in accessing, but we also know that telehealth is not an evidence-based solution or intervention for every healthcare need. And so I think that it's really important for us to continue to follow the science, to continue to do the research, because we don't want to miss the opportunity to help connect patients with the best care modality, not just an acceptable or an convenient care modality. And I think that we've seen extensive disparities, not just in COVID rates or deaths, but also we've seen a variety of, non-COVID increases in cause of death. We've seen a lot of spikes in mental health and suicide attempts or completions. And obviously the work that I've been doing in the maternal health space has been one where we've seen enormous inequities during this time of a pandemic. And I would say that efficacy of the telehealth intervention is mixed, even between those examples. And so we want to make sure that as we're moving out of this pandemic, that we are continuing to embrace innovations and interventions that will help people and really help them solve their healthcare challenges.
Well, talk to me a little bit more about maternal health and maternal mortality, because I think every time we talk about those numbers, people's eyes pop wide open. The last year I think we have data for was 2019, and there was an increase in maternal mortality,
Yes.
a 15% increase in the US. Do we yet know the impact of the pandemic on that number?
We know because of some early data that came from JAMA, the Journal of the American Medical Association, and the CDC's internal scientific publication, the Morbidity and Mortality Weekly Review, that, for example, Black and Hispanic pregnant people or birthing people were more likely to get COVID-19. They're more likely to get severe illness. And there's this dangerous, or at times dangerous, correlation between COVID and maternal health outcomes that really did not yield a positive outcome for our nation's maternal mortality rates, right? We know that during the pandemic, it did not decrease. And we also know that during the early days of the pandemic, when people were encouraged to stay out of our healthcare system, it was really a time of trauma for birthing people in this country who were entering into hospitals or birthing centers without their support systems, without their partners, without their doulas, and so in a crisis, right, a maternal mortality crisis, where we know that, in particular, Black birthing people often aren't heard when they say something's wrong, when they say I'm in pain, when they say I need help, when they don't have that partner or advocate there with them, it increases the level of stress and possibly trauma that they experience.
Dr. Butts, what about that? Because maternal mortality is just one example of how endemic racism impacts people's, their health, their well-being, their lives. So I hear you saying you hope that we get there. You hope that those lessons do carry forward. Let's talk about what is being done. I mean, give us some examples, especially in the Mount Sinai system. What kind of conversations are you having?
Yeah, I think, listen, I've been in this space. First, I've been in Mount Sinai for quite some time, and all my life, my professional life has been committed to addressing the ills and the challenges for poor communities of color. The past 20, I've been overseeing diversity, equity, and inclusion efforts for our health, for our school, and now more recently for the system. We have never gotten the kind of attention and the visibility that we've gotten over this past year. We've been in a crisis. And I think the good news is that we've been able to talk about race and racism. And so about a year ago now, I was charged to pull together a task force to not just talk about, but to come up with strategies and tactics and a process to go deep and broad in addressing racism across our system. And so the result of that is a roadmap not just a bunch of ideas or a strategic plan that sits on the shelf. A roadmap with a process and to address 11 strategies and over 50 interventions or tactics that will get us there. And we recognize that solutions will require something from all of us. And while there were 50 somewhat individuals on the task force, that allowed for broad perspective sharing, and we've been smart about it. We have a system of over 40,000 staff, and so we need to ensure that we are defining the issues in ways that relate to us all, and so that the solutions that we aim towards are meaningful and relevant, and of course possible to achieve. So we're well positioned to move forward. We have become comfortable being uncomfortable, talking about these tough issues. So that's an important first step. And now it's about rolling up our sleeves and getting and moving forward. We do have the support of our most executive leadership, including our CEO and our trustees, to do this work.
Dr. Wen, what's been your experience in this part?
Yeah, so I so appreciate everything that Dr. Butts just said, because I think that so often, first of all, when we talk about issues that are complicated, and certainly the contribution of racism to healthcare or racism to health outcomes is very complicated. Sometimes there's a tendency to say, well, so many factors are involved because it's race, it's poverty, it's educational outcomes, it's job security, it's public safety. They're all kind of wrapped up and they all contribute to health, and health contributes to all of these factors in turn. Sometimes I think there's a tendency to almost be paralyzed by inaction. And there's a tendency to just, if you will, admire the problems and point out the problems, which I think is really important. Acknowledging the problems is an important first step. But I think we're in this moment where we have to move very quickly to solutions, or else we're really just talking about things. And I think there are really urgent needs that have been unveiled by this pandemic. And so I really appreciate what Dr. Butts was just saying in terms of the actions that they're taking. I would also say that I think we've moved really far when it comes to finally acknowledging racism as a public health crisis. I remember back in 2015 in Baltimore, right after the death of Freddie Gray, while in police custody. And I remember we in the Baltimore City Health Department were talking about racism as a public health issue, but we got raised eyebrows. And in a way had to back into this issue, as if we had to talk about how, well, there are health disparities that are based on race. And therefore, if we're talking about poverty as a public health issue or violence as a public health issue, then racism itself is a public health issue. So we had to back into this and explain it, versus now I think people understand it. And so I would just offer a couple of things by way of what can be done. One is, I think, setting metrics is really important. And I'll give you an example of this. In Baltimore, we had and still have a very successful program called Be More for Healthy Babies, where over 150 public and private partners came together with one goal, and that goal was to reduce infant mortality in our city. We were faced with a situation where Baltimore had one of the worst infant mortality rates in the country. Black babies were 5 times more likely to die in their first year of life than white babies. And so we committed to reducing infant mortality, but also said that's not enough. We have to very critically close the gap between Black and white infant mortality. So with a combination of home visiting programs, providing cribs, providing resources for expectant moms, postpartum visits, etc., we were able to reduce the infant mortality in our city by 38% in a 7-year period. But very critically, we also closed the gap between Black and white infant mortality in that same period by over 50%. And so I give this example because I think that it is possible to do, even with a complex issue like infant mortality. You address it using these wraparound services, being attentive to the social determinants of health. But I think a critical element moving forward is, I hope we also attach a disparities metric, an equity metric, especially because, and I say all of this because I think so many people in this audience, you are the operators, you are the people who are getting this done. And I think there is a way for us to move out of this period and be really attentive to the actions that we have when it comes to improving health, but very importantly, being zeroing in on the goal of equity too.
Just to follow up on that, Dr. Wen, and specifically to public health, which is, of course, an area you know so well. You have a book coming out about it next month, we should know too, which talks about your experience in this space. But it's such a big system, and some of these systems and processes are so well entrenched, and momentum and inertia are incredibly powerful forces. As Dr. Butts mentioned, it took a crisis to get us to talk about racism in this way, to acknowledge the deep inequities in our system. Are you worried that the further we get in our progress moving out of the pandemic, the urgency goes away?
Yes, and actually, I'm also worried that, although I'm very glad that public health as a whole has been really emphasized through the pandemic, I'm really worried that we're only looking at public health through the lens of infectious control of infectious disease and infection control. Very important. I of course want us to focus on vaccines and testing and contact tracing, etc. But there's a lot more to public health than that. We have issues that were already epidemics prior to the pandemic. We had the mental health crisis. We had the opioid epidemic. We had obesity as a crisis in our country, among many other public health issues that have been, if anything, exacerbated because of the pandemic. But we're not paying attention to that. And so I do worry that the urgency is going to wane. People are going to be sick of talking about public health. There might be an infusion of funding into infection control, but we're not actually addressing the underlying issues. And so I would challenge those health systems, community organizations, other listening and participating here to actually go beyond the pandemic and COVID-19 itself and to see what are those tangible things. Maybe not everything. You know, I think it's great that Dr. Butts has 11 things that they're addressing, but even an individual can address one thing that I think would make a tangible difference moving forward.
Congresswoman, what about this idea of the urgency of the moment and innovating and coming up with solutions? Because we saw Congress move very quickly in a crisis. We saw people come together and come up with solutions. When it comes to health equity, does it have the same sense of urgency?
I think it does. Everything that the Congress is doing may not have the equity label hung to it the way that the Biden administration has been upfront in putting equity as a key priority. I think about the funding that was included in the American Rescue Plan, a historic level of funding for public health workers, right? HHS has just gone out within the last month with $250 million in funding for state and local health departments to invest in workforce, because what we know about state and local public health is that they were operating at the top of their capacity before the pandemic. And then you layer on a pandemic like COVID-19, and all of a sudden, these normal public health functions, like Dr. Wen was speaking of, right, priorities, key issues that municipalities and counties and regions had been focused on, had to take a back seat to pandemic response. We want to make sure that they have a robust workforce filled with people that come from community, that are culturally and linguistically aligned with that community, that they are able to then become skilled experts in local public health and become those practitioners, and that workforce stays in public health long past this pandemic. So what we've done with the COVID response is made a overdue down payment to help modernize our public health workforce. And I think that commitment will certainly continue forward as we recover from the pandemic. And I think that we should not discount the power of these investments to drive forward an equity agenda. But what it requires is local accountability. It requires local visionary leaders that will call out and make commitments to equity, to inclusion, to ending disparities, to make sure that this new, robust, well-funded workforce has their marching orders, has systems in place to track the metrics, and has, quite frankly, the freedom to call out a problem as a problem and work aggressively towards calling out those solutions.
Can I ask you to follow up on something where we are right now as a country, though? In vaccine delivery, for example, there were so many innovations. We saw so much more effort from this administration with mobile health units and public-private partnerships and so on. And yet still, still the inequities persist, right? We know that the full vaccination rates for Black Americans in particular lag behind those of white Americans. So when you look at that and you look at some of the ideas that have come out of the pandemic in the last year, what's not happening now that could be and should be in the future?
Well, we're talking about when you talk about, let's take the African American community, for example. We're talking about a group of people that have traditionally had more limited access to healthcare, may not have a primary care provider, don't have these deep trusted relationships with maybe either a healthcare system or public health infrastructure in their community, may not. And so in that instance, in the time of a pandemic, that trust is not immediately built. And so there were some assumptions made in this response that, oh, well, even if a community doesn't have a healthcare provider that they usually see or a trusted community health center, they'll want to go and get a shot at Walgreens from the random pharmacist that's there. That is not necessarily the case. And so I think, and especially when we talk about young people, because that's the challenge right now, right? We're seeing young adults, 16 to probably 30 in terms of people of color who just are not enthusiastic about vaccine uptake. Well, when we think about the healthcare messages and the healthcare habits of this community of young people of color, this should not be a surprise. And so we have a lot of work to do just to improve their health status, to increase their connection to healthcare. And I think that as we make those key investments and prioritize this, then we will see an uptake in vaccination efforts. I also think, in healthcare, we have long ignored the role of viral disinformation, and we cannot put our heads in the sand any longer when it comes to the messages that people are receiving on Facebook, on Twitter, on Instagram, on Snapchat, on TikTok, right? Like, people are consuming healthcare information in ways that are completely disconnected from any traditional healthcare source or healthcare media. And those messages are penetrating, not at just a personal level, but as a cultural level. And we have to be more assertive and more aggressive and more intentional at meeting people in the spaces where they're receiving this healthcare information and offering trusted messengers to discount it.
Dr. Butts, I want to come back to something you mentioned early in our conversation, because it's so crucial right now, and that's the issue of mental health. Not just the crisis that existed pre-pandemic, but the deepening need after a year of isolation and uncertainty and anxiety. Have we put into place the resources needed to meet the need?
Yeah, I think that it's not clear to me what's happening nationally, but certainly we've had no choice but to focus on wellness as a part of the challenge and addressing people in our communities during this past year, and that includes our healthcare workforce. And so talking about it is possible now without folk feeling stigmatized. Folk have been stepping forward. We at Mount Sinai have been studying the issues more directly and investing resources in intervening and what has been yet another pandemic. And so how do we sustain both the focus and the necessary investment as we move forward is a question, and that's going to require more than an individual institution, frankly. But clearly, mental wellness goes hand in hand with physical, sometimes even more important, particularly during these tough moments like a year of a pandemic and then some. And so I think there is focus now. Let's maintain that. I think just like public health, until we see the size of the problem that we've had, it almost doesn't exist. And so that's the challenge. Let's keep the focus, just like focus on racism. How do we sustain the focus as people become tired of talking about it and overly fatigued in trying to address these very, very tough issues?
Dr. Wynn, when you look at the last year and some of those innovations, some of those practices that were relied upon more heavily in a way they hadn't previously in telehealth and mobile health and so on, can any of those be put towards addressing the mental health crisis that we know exists and is getting worse?
Well, sure, absolutely. I mean, I think that the issues of mental health, as everyone has mentioned, is deeply interrelated to everything else. The same disparities that we're seeing in mental health access are also mirrored in physical health access as well. But there's an additional challenge, which is that mental health, frankly, is stigmatized. When someone says that they were diagnosed with depression or anxiety, they don't get the kind of sympathy or time off or whatever it may be if they said they got diagnosed with diabetes or heart disease, right? We don't treat these things the same way. It's not reflected in our insurance reimbursement system. It's not reflected in our society. There is the sense that somehow it's your fault. It's something you could control versus we're never going to tell somebody just buck up and your diabetes will go away, right? I mean, we think about this in a different way. So I think recontextualizing mental health is going to be important in this conversation as well. But yes, I do agree that we have to work on increasing access. And I hope that moving forward, there's going to be more consideration of the whole person. A person isn't just one thing. You don't just, as a person, when you go to the doctor's office, you're not just getting treatment for something that's in your chest. It can't be separated from how you are, how your mental health is. Your reproductive system doesn't just exist in isolation. To Congresswoman Underwood's point, when we look at issues of maternal mortality as an example, yes, there are things that we should focus on during labor and delivery, but we also have to acknowledge that maternal mortality occurs because women's health was not attended to prior to pregnancy. Women were not healthy prior to pregnancy. Then postpartum, they lose their health insurance and can't get their ongoing medical issues, including their mental health issues, addressed. And so I think I would love to see innovations moving forward where we're really addressing the whole person's health in one visit. That, to me, is the ideal because that's what patients want. You don't have patients who say, yes, I voluntarily want to go to 5 different people in order to treat these issues. They want to go to one location, ideally at one time, where they're able to treat everything for themselves and for their families as well. And I'll just add too, I think that, this in a way ties to the conversations around COVID-19 and vaccines as well, because we've seen early on in the pandemic that it was kind of build it and they will come, right? It's the people who are really eager to get vaccinated. You set up locations and they'll get vaccinated. Now, we really do need to meet people where they are, specifically if people are coming in for their hypertension checkups. We should be offering the vaccine at that point. If people are coming in for mental health visits, we should be offering vaccines at that point. That, I think, is another example of why that integration of healthcare and treating people as a whole person, why it's so important, but also why at this time in the pandemic, we should see this as a critical outcome going forward.
We have just a few minutes left, but I want to make sure everyone in the audience taps into the best of your expertise that we've assembled here and gets a kind of key takeaway that they can walk away with and try to implement. So I wonder if we can kind of go around to each of you and just ask, what would you say to people out there watching as one thing they could do, one step they could take in each of their organizations that would help to close some of those existing gaps that we know are in America right now, that would help to advance health equity right now? Dr. Wen, I'll start with you.
I would say start somewhere because yes, there are big problems, but you alone can't do everything. And if everything is a priority, nothing is a priority. So don't be paralyzed by all these huge problems that we have. Choose one concrete thing that you can be doing today. Maybe that's expanding testing for unvaccinated people. Maybe it's starting a mobile vaccination program. Maybe it's something as basic as convincing you're speaking to your neighbors or speaking to coworkers about the importance of vaccination and helping to overcome myths and disinformation around it. I mean, whatever it may be, or maybe it's something related to one of the other public health issues that's been neglected, but start somewhere. Don't let perfect be the enemy of the good. Don't be paralyzed by inaction.
Congresswoman, what about you?
We are asking a lot of our healthcare systems. I understand that, but we all have a role to play, and they hold unique data sets. Let's do some analysis. Let's set some goals, to Dr. Wen's point, and then let's support our individual providers in their work to do outreach in the community to end these disparities. I mean, it will take leadership at the local level, commitments from healthcare systems working with state and local public health, and quite frankly, frankly, local leaders, elected and otherwise, in order to solve these problems. But a lot of folks are operating in a data desert, so to speak, right? Healthcare systems are the ones that are most likely to have real-time data that's available in terms of trends, in terms of disparities, in terms of outcomes. And if healthcare leaders would open up those data sets, make sure that everybody's in the loop and that providers feel supported as they pursue these interventions, I think it would go a long way.
Dr. Butts, you have the final word here.
Three quick things. I know you asked for one, but I would say number one,
We'll take as many suggestions as you have.
hey, let's agree that it's okay to be uncomfortable in these spaces, and let's figure out a way to include even the most invisible amongst us who are on your teams, in your shops, in your institutions, to begin the conversation about equity and aim towards that uncomfortable conversation about race and racism. So that's number one. Number two, allow folk. Just imagine how many folk would feel that much more valuable if they felt they were visible. So that's part two. And the other is, you don't have to have it all figured out, but clearly when folk ask me, how can I be helpful? My response typically is, well, let's figure out a way for you to carry the bucket at least a little bit of the way. Because for those of us who have been at this task, whether it's through public health or through primary care or social service provisions, it's a heavy bucket to carry, even more so these days. And so let's figure out a way so that we can all hold ourselves accountable to carrying the bucket at least on some part of the way. And then we can get there. We cannot do this alone, either as people of color, as women, as LGBT community. We have to do this collectively, particularly with folk who have the power and the privilege to make the change, get us to the change that is necessary in this space.
That is Dr. Gary Butts, Dr. Lena Wen, and Congresswoman Lauren Underwood. Thank you so much to all of you for being here in conversation today. And here's to all of us doing our part to carry that bucket a little further down the road. Thank you again.
Thank you.